এটা দিয়ে ইউজ করতে পারেন। আপনি স্লাইড চেঞ্জার ইউজ করতে এটা দিয়ে দেবেন।
Honorable discussion and learned audience, Assalamu alaikum and good noon. I am Dr. Mohammad Abu Zahid Basunia, Assistant Professor, Rangpur Medical College and Hospital. My case is a very rare case. Being practicing in adult cardiology, I had the renowned pediatric cardiology, a little bit uncommon thing, and my case is also the uncommon thing. Mycobacterium endocarditis. Endocarditis is referred to as the infection in the endocardium, the inner lining of the heart chamber and heart valves. In United States alone, approximately 15,000 new cases of infective endocarditis are diagnosed each year. And annual incidence of infective endocarditis is 10 per 1 lakh of general population and carries mortality up to 30% at 30 days. The modified Duke criteria are used to help establish the diagnosis of infective endocarditis. The organism itself is exceptionally resistant to conventional antibiotics. We know the 4-drug combination, fixed dose combination need months together to cure the diseases. And it potentially can infect every organ of the body, including the heart. But can Mycobacterium tuberculosis causes endocarditis? Yes. Tuberculous endocarditis was first reported in 1892, and subsequently many other cases have been described, highlighting the significant morbidity and mortality associated with this manifestation of tuberculosis. Tuberculous endocarditis is usually present with miliary tuberculosis, and most early cases were diagnosed on autopsy. And granuloma caused by Mycobacterium tuberculosis have been observed at autopsy in heart, predominantly in the myocardium and endocardium. And summary of the available management of tuberculous endocarditis throughout time. In 1900, there was no echocardiogram or tubercular blood culture. So in 1935 to 1950, the patient treatment done, dead, and autopsy. On autopsy, it is proven Mycobacterium tuberculosis up to 1950. And after that, echocardiogram come and tubercular blood culture. Then anti-TB drug were coming and doing a lot of job. So a boy, 5 years old, presented to our cardiology department, Rangpur Medical College Hospital, Rangpur, with a history of fever for 20 days. He had also a history of respiratory distress and malaise for 14 days. On examination, the patient is toxic and dyspneic. Anemia present, temperature raised, respiratory rate was 30 breaths per minute, JVP raised, and first and second sound are soft. And investigation report, hemoglobin percentage little bit low, 9.8 gram per DL, WBC 11,000 per cubic millimeter blood, ESR raised 50 millimeter per in first hour. And on chest X-ray, that is huge cardiomegaly, the globular shape or pear shape of heart or clean cut margin with oligamic gland filling. This is the definite of pericardial effusion. So, what to do with this scenario? There is a huge pericardial effusion, huge cardiomegaly, and the patient is fever, toxic. We go for echocardiogram, and on echocardiogram there is severe pericardial effusion, that is 27 millimeter posteriorly, 13 millimeter anteriorly, and 20 millimeter laterally on the LV side, and 70 millimeter on the RV side. And features of early pericardial tamponade was present. The heart is swinging around the fluid, and there was diastolic collapse of RA and RV. RA is less diastolic collapse, RV is early diastolic collapse. And also there is dilated IVC, infravena cava, with loss of phasic collapsibility. And there are multiple tetracles, that is the echogenic fibrinous stents were found in the pericardial fluid. And interesting thing is that there was also vegetation around the upstream side of the anterior and septal leaflet of tricuspid valve, and also vegetation attached to the Posterior leaflet of mitral valve on the left atrial side. Vegetation shown in a oscillating movement. Here is the pictures. Sorry, I am the still picture. I cannot collect the movement live picture. Echo showing pericardial effusion with vegetation in the tricuspid valve, both leaflet, anterotricuspid leaflet, and also the septal leaflet, and vegetation also are attached to the PML of mitral valve. And there is huge pericardial effusion involving this is the apical four-chamber view on the lateral side of the RV in this picture. And there is fissure of pericardial tamponade. So with this finding, what to do? As there is the fissure of pericardial tamponade, we must trap to pericardiocentesis. This is another picture. Here is shown tricuspid vegetation in the anterior septal leaflet and also anterior tricuspid leaflet and the huge pericardial effusion. So we go for pericardiocentesis, and it was done. 30 ml milky color pericardial fluid was aspirated and sent for examination. This is the color of the pericardial fluid. Why milky color? Because there is lymphatic exudation. And as soon as the pericardial fluid was drawn, the patient felt comfort and relief of respiratory distress. And the pericardial fluid was sent for the study, and the report came with the adenosine D- test, that is 195 unit per liter. This is very much sensitive and specific for Mycobacterium tuberculosis. And protein is exudative, 9 gram per dl, sugar nil, pus cell plenty, no malignant cell, and FB present on ZN Zilnanson stain. So exudative pericardial infusion with ADA positive, with FB present. But on blood culture, to diagnose the infective endocarditis, it is mandatory, no growth of bacteria. Traditional blood culture show no growth of bacteria. That is a negative blood culture report. So what should be the final diagnosis? Tuberculous pericardial effusion with mycobacterial endocarditis. And as soon as the pericardiocentesis was done, the patient felt comfort, and anti-tuberculosis drug, 4-drug regimen was given as per the guideline regimen for 5-year child weighing 14.5 kg, the WHO guideline, fixed dose combination, remester 3 FDC, given 3 tablet once daily, and also the boy is 5 years, so ethambutol is also added, 100 milligram 3 tablet once daily. With this combination goes for the initial phase and continuation phase 2 and 4 months, 6 months. And after the completion of the treatment, the patient is feeling better, and this is the final echocardiogram after treatment. Here we show no vegetation, almost absent, and pericardial effusion almost absent in this picture. So with this, we may cause that pulmonary tuberculosis can affect the pericardium, causes pericardial effusion, and involvement of the endocardium. The valve involvement is the mitral valve and tricuspid valve, though it may infect aortic valve. In this, we cannot see aortic valve. We cannot do transesophageal echo. So we cannot say that aortic valve involvement of vegetation present or not. With this, thank you. Thank you very much.
Thank you, presenter, for your nice presentation. Now it's question answer time. Question from audience.